Welcome. Welcome to MedCognito's MCCQE1 review class. You know, today is the 17th of October, and I'm excited to really see everyone here. And I'm glad that you're spending your afternoon with us. So what is going to happen is that today's focus is going to be on a very critical thing: early pregnancy loss and spontaneous abortion, and the approach you should use. However, as we usually do, we're going to also learn approaches to solving MCQs, okay? So we'll do some MCQ questions. What I would need you to do is, number one, the main thing we'll be discussing will be early pregnancy loss and spontaneous abortion, because it's a very major objective in the MCCQE1 exam preparation. However, I'll also bring up a couple of MCQs and one or two CDMs so that we can review the approach. Because a lot of people go like, Dr. Bruni, what is the approach? Dr. Alex, what is the approach? Dr. Tino, what is the approach we should use in solving MCQs? So today, what we're going to do is that we're going to reason through the MCQs. We're going to see how to reason properly through the MCQs in order to score the highest point you can ever score. So let's get going. So today, as I said, the objective we'll review will be early pregnancy loss and spontaneous abortion, because so many things present in that particular category, but at times people get confused about it. But before that, let's get some MCQs going, because that's also a very critical part of the exam. The CDM is also part of it, and then we can then use the objectives to pair things apart. So I need somebody to raise the hand for the first question. The first question. Who wants to do it? Dr. E-Class. Dr. E-Class. Dr. E-Class. Yeah. Okay, good.
Yeah.
Dr. E-Class, let's go. Sure.
Okay. A 28-year-old male involved in a hit-on collision was brought to the ED by EMS. Estimated blood loss was 2.2 liters of blood. On exam, the patient is in distress with cold extremities with unrecognizable jugular venous pressure. Vitals: heart rate 150 beats per minute, oxygen saturation 96% on room air, respiratory rate 24, temperature 35.5, and the blood pressure 84/55 millimeter mercury. What classification of shock is the patient experiencing?
Awesome. Please send me your answers privately while Dr. E-Class works through this. So Dr. E-Class, this case you have, is it hypovolemic? Is it cardiogenic? Is it distributive? Is it obstructive? And why? You know, I know that you may choose one answer, but what I want you to do is reason through it with me. Let me know why you are choosing it so that I'll understand that you understand the concept of shock, because shock is a big thing, big objective in the exam.
Yeah.
Okay, good.
Yeah.
What is your answer?
Hypovolemic shock.
Hypovolemic shock.
Because it is traumatic patient, blood loss, high blood loss, and there is a tachycardia and hypotension. That's all, and the jugular venous pressure is normal, not increased.
Okay, good.
So, and the temperature is low. If it is high, I may think about distributive shock. If the jugular venous pressure may be cardiogenic shock or obstructive shock, but this is the signs of hypovolemic shock.
Beautiful. So you see the way you've gone through this. You've seen the way you started from, you know, the blood loss, the mechanism of injury, and Dr. Yayulin says C because cold extremity and JVP is low. Dr. Sumaya Khan says C. So almost everybody agrees it is C. Now let's reason through it. So the answer is C, true. Okay. Now, what I've realized is that some of us make the mistake of in the exam, what is the most, but at times we don't have a way of reasoning through it. And remember, shock is a very, very important objective. And that is why I brought it up. A very important emergency medicine MCCQE1 objective. So The rationale, this is the reason. This is the reason. And Dr. Callis did very well. This patient has cold extremities and low JVP. And it is from the intravascular volume depletion. This leads us to say that this shock is hypovolemic. And the exam trick is this: when you are in the exam and the patient presents with cold extremities and low JVP, it is two things. Two types of shock can present with cold extremities and low JVP. So don't just say that, oh, this is hypovolemic shock just by it, because two types of shock can do that. Number one is decompensated distributive shock. It can lead to JVP being low. It can lead to cold extremities. And hypovolemic shock can also do the same. However, because this guy was involved in a motor vehicle accident, and it is obvious that the patient has lost blood, that is why we can't go for distributive shock, but rather we will go for hypovolemic shock. So, Dr. Ikalis, I have another question for you. What in the history would have rather led you, assuming the history did not say the patient was involved in a motor vehicle accident, what in the history would have led you to say this is a distributive shock? Because now we are learning that both hypovolemic and distributive shock can cause low JVP and cold extremities. Are you getting my point? So what will you be looking for in the question stem, which will lead you to say that, no, this one, it is distributive shock? Dr. Callis, are you there?
Yeah, I'm here.
So what are the things you are looking out for in the history?
The distributive shock, I want to ask you, it is the same as anaphylactic shock?
Anaphylactic shock is a type of distributive shock.
Yeah, because anaphylactic shock come with the vasodilator.
Yes.
Camouflage.
Yes. Yeah. So that means you are looking at maybe exposure to an anaphylactic agent. That's one thing. What are other causes of distributive shock?
Maybe burn.
Maybe what?
Burn. B-U-R-N.
Burn. Beautiful. So that's it. So these are the things you want to look out for. So this is a very, very important algorithm. Number one, in the exam, if the patient, you think the patient has shock, right? Beautiful. Dr. Faisal says sepsis. So sepsis, you are looking at a history of fever. So if you get the same patient and then you get a patient and they say that maybe the temperature was 39.5 and JVP is low, think about distributive shock. So now, two things here. First, if you get a case of shock, you're looking at two things. First, is the extremity cold or warm? That is where you want to start from. This patient, we learned that the extremity was cold. So that means that that patient cannot follow this algorithm. Forget about this algorithm. Forget about sepsis, anaphylaxis, burns, neurogenic shock. Forget about that. But rather come here. So if the patient has cold extremities, now the next level you want to go to is the patient has cold extremities. What about the JVP? If the JVP is low, then because of cold extremities and low JVP, you can rule out confidently the compensated distributive shock, cardiogenic shock, and obstructive shock. I want to make this simple. So if you get a case, look at two things. First, what are the extremities? Are they cold or are they warm? If they are cold, ask yourself the next level. So when you are dealing with shock, extremities, next level, JVP. If the JVP is low and extremities are cold, think about hypovolemic shock. It is hypovolemic shock until proven otherwise. So think about things like hemorrhage, and this patient had blood loss. Think about dehydration. Think about vomiting. Think about diarrhea. Think about interstitial fluid redistribution. That is what your focus should be on. However, if the patient has cold extremities and increased JVP, then it moves you from hypovolemic shock to either obstructive shock or cardiogenic shock. All right. So cold extremities can be three types of shock: hypovolemic, obstructive, cardiogenic. But if the JVP is high, then forget about hypovolemic and go for cardiogenic or obstructive. And with the obstructive, you are looking at a patient with pulmonary embolism. So if they say that the patient develops sudden onset of chest pain, or a patient who has not been mobile or recently had surgery and has been at home and suddenly developed chest pain, cold extremities, high JVP, boom, obstructive shock. Same thing, maybe patient was hit in the chest for whatever reason and trachea is deviated, cold extremities, high JVP. I'm thinking about obstructive shock secondary to tension pneumothorax. So please, when you get a replay of this video, take your time and review this chart very well. In fact, this chart is taken from the Black Book from the University of Calgary. Very important book. You can check them out. You can check it out and then use it. Usually they have algorithms. So shock, they have algorithms for almost all the MCC objectives, okay? However, if the patient is presenting with signs of shock and the extremities are warm and the patient has low JVP, so warm extremity, low JVP, think about distributive shock, sepsis, anaphylaxis, burns, neurogenic shock. So please, are we all on the same page? Because this is very important. This is a very, very important way of, differentiating between the types of shock just based on the algorithm. So if you get a case, there's no need to guess. It is about looking at the vitals, looking at the clinical presentation, and based on that, deciding what kind of shock the patient has. Can I proceed? If I wanted to take advantage of this case to review shock, and we've used this case, of course, to review shock in an interesting way. Okay, so now, Dr. Maria Khan, because you wanted to do the next question, I bring you the next question. Dr. Maria, are you there? Dr. Iklas, thank you very much. That was awesome. Dr. Maria, let's go.
Yes.
Let's go.
So a 28-year-old male involved in head-on collision was brought to emergency by EMS. Estimated blood loss was 2.2 liter.
Dr. Maria, can you lift your voice a little bit? Your voice is very low.
Sorry, a 28-year-old male involved in head-on collision was brought to emergency by EMS. Estimated blood loss was 2.2 liter of blood. On examination, the patient is in distress with cold extremities and unrecognizable JVP. Vitals, heart rate 150, oxygen 96%, and respiratory rate 24, temperature 35.5, and BP 84/55. Choose the next best step, as many as they apply.
Beautiful. So this is a CDM. This is a CDM. So Dr. Maria, which one will you go for? Which one will you go for? And why? So this is a CDM. This is not an MCQ. This is a CDM. Which one will you go for and why?
So the patient is in like hypovolemic shock. So the first thing I want to check the ABC.
Okay.
Is the airway, breathing, and circulation. And then the blood pressure is pretty low. So I want to correct the blood pressure. So I will give the fluids like crystalloids, D.
Okay.
So F and then D.
Okay. So that's your answer, F and D. Okay. So Dr. Maria Khan, my question is, why didn't you choose A? What is wrong with A?
A, norepinephrine vasopressor can be used to to increase the blood pressure, but I think the third thing is the fluid resuscitation.
So you think the main thing is the fluid resuscitation. So why didn't you choose B? This patient is involved in motor vehicle accident. Why didn't you choose B? Give 2 units of O negative blood and consider massive transfusion protocol if still hypotensive. Why didn't you choose B?
So after giving the fluid resuscitation, we can give the if blood is needed, then we can give the blood transfusion after
Beautiful.
the fluid.
Beautiful. So Dr. Esmat Razoli says B is very vital. So Dr. Khan, can we say that yes, F is correct? Yes, D is correct. For example, in a patient with this kind of trauma, you may not want to give more than 3 liters of fluid. The reason is because it can lead to dilutional DIC. Okay. For example, the person is losing blood and all the person is getting is fluids. It will get to a time the blood will become so dilute. All right. So in trauma management, as soon as you've given about 2 to 3 liters of fluid, the next level you are going for is blood. So in a case like this, if I was to mark, Dr. Khan, you get 2 out of 3. And that is a very good point because you chose the most important things. However, now this is another trick. This patient does not need CPR, okay? Number 2, this patient does not need norepinephrine and vasopressors because you've not even finished with the fluid, you've not finished with the blood.
Yeah.
And E is a dangerous answer. Now, this is another trick a lot of candidates don't know. In the exam, you don't want to choose a dangerous answer. What do I mean by a dangerous answer? E is what we will call a dangerous answer. How can you tell me that this patient has a heart rate of 150, an oxygen saturation of 96 on room air, a respiratory rate of 24, a temperature of 35, and a blood pressure of 84/55, and you are only going to do watchful waiting for the patient's condition to improve? If you choose an answer like that in the exam, it is considered that you're putting the patient in harm's way. And so you might have chosen B as correct, D as correct, and F as correct. But if you add an answer like E, what happens is that the whole, that part of this exam, this whole question, then you get 0. So you know what? You are better off choosing, I'm just saying, if you are not sure, you are better off choosing just giving crystalloids alone. That will give you 1 out of 3. Or manage the patient's airway, breathing and circulation and crystalloids. That will give you 2 out of 3. If you know the B, that will give you 3 out of 3. However, if you choose B, D, and F, which are all correct, and you get 3 out of 3, and you add E, it nullifies your whole answer. And so you get 0. Please, are you following me? Because that's also a very critical point a lot of candidates don't get, and that is a mistake they make. So if I
have a question
an exam and I'm not sure, I'll just choose B and F so that I can get 2 out of 3, rather than to choose B, D, F, and E, and rather get 0. All right? And rather get 0.
I have a question.
Please ask your question.
This question is like a prototype of what I've seen before, real life. I just don't want to go for that. But
Sure.
the question came similar to this. It was a CDM question and had just one option. And the option was you have to write it down. They said, what is the first thing you will do for this patient? What
Okay.
is the first thing you will do for this patient? So I was confused. Should I do airway? Should I manage the airway? Should I manage the breathing? Should I manage the circulation? So which one out of these 3 should I do for this patient? It was just a single question. It was just like that. Number 1, nothing else.
No, that one I'll go for airway management straight. I'll go because that one will kill the patient before circulation will kill the patient. So in trauma, I'll go for airway management if I'm supposed to give my first answer. However, if you are given, say, 4 options, I'll go for airway management, breathing, circulation, and then fluids. So that is how I'll and then don't forget that the management of circulation is giving fluids and blood. So in fact, fluids and blood are not different from C. Okay, so what you can, and don't also forget that you don't necessarily have to write single word answers in your exam. If you don't get a single word to really explain it, you can use, say, manage circulation with IV fluids and blood. That's also acceptable. Okay, rather than saying circulation management. When you say circulation management, what do you mean? Dr. Onos, are you following me?
No, I'm following, but that's what was there. Will you manage the airway? Will you manage the breathing? Will you manage circulation with crystalloids? You understand? You have to choose one out of these three.
No, so I'll go for airways first. I'll go for airway. Airway should be your number one thing. Okay. He means each is one answer. Dr. Masuda, can you please help us with what you mean? I don't get it. Maybe if you can explain further.
Yeah, just airway, breathing, circulation. If we have CDM, we should consider each one answer.
Yes.
Well,
Okay.
What if three of them are in the option and you have just three options and you have to choose one? You have to choose one out of the three.
Airway management.
So
in trauma management, go for airway management first. Whenever you have to deal with a trauma case, make sure airway is number one.
So is there any condition where C will come first, where circulation and crystalloid will come first? Is there any condition where this ABC pattern can be twisted? Like you can go from B or start from C?
No.
Go for airway. Go for airway first. Unless the question itself tells you that the airway has been secured. If it says airway has been secured, then don't worry yourself about it. But if I'm to choose between those three, I'll go for airway management straight up. I'll not even think twice about it. Go for airway management. All right, good. Any other question before we continue? What if O2 starts are good? So if O2 starts are good, it does not necessarily mean that airway has been managed, because you are just assessing the patient. And at times, airway management is just doing a jaw thrust and chin lift. So don't assume, even though it says that the O2 SAT is good, don't assume. Make sure that you've reviewed the airway. Is there any, is the tongue falling back? Is there any foreign body? Is there any blood? Is there any denture falling? Is there any hematoma which is forming? You want to deal with that first. And in fact, even in your narcolepsy, as you go through the airway, breathing and circulation, if airway becomes compromised again, you want to go back and go and assess airway again and come through breathing and circulation again. So all the time, go for airway. Kill airway first before you move on. All right, good. Another question. Okay, awesome. Yes, if question chose one, go for F, airway, breathing and circulation. Yeah, that is it. If it is just one, just go for F. Okay, let's continue. So this is the answer key. So the answer is B, D, and F. The issue is that you will get 0 for the whole question for choosing E, which is do watchful waiting for the patient's condition to improve, since he's in reflex hypotension, since this is a dangerous option. So all the time when you are doing your CDM especially, look out, be careful, look out. Is there any dangerous answer I'm choosing? If there's a dangerous answer and you're not sure, stay away from it. Stay away from it. You are better off, the trick with CDM is that you are better off choosing the 2 so that you can get 2 out of 4 than to choose 4 and out of those 4, one of them is a dangerous answer and then you get 0. Please, are you getting the point? So you can get somebody who is very careful and choosing his answers right, and the longer the person may do better than somebody who goes, oh yeah, the person gets all the 3 right, but the person gets 1 dangerous answer and everything becomes 0. So the main management in hypovolemic shock is, in shock, always assess ABCs, always. And the main management is fluid replacement. In this patient, you want to control bleeding and resuscitate with fluid. Vasopressors are not recommended in the management of hemorrhagic shock. You want to use vasopressors in the management of septic shock, not hemorrhagic shock. All right, good. Another volunteer, I need another volunteer so that we can get things going. Another volunteer, please. Who wants to volunteer?
Can I?
Sure, Dr.
Yeah,
Fatin Al-Sadi, please.
38-year-old female who is a smoker with a negative urine pregnancy test to the ED with vaginal bleeding for 10 days with normal vital and an unremarkable pelvic exam. Her hemoglobin levels are 110. Which of the following would be the most appropriate management? Combined oral contraceptive, IV.
Please.
Okay.
Mm-hmm.
So she's smoker. Pregnancy is negative in the ED with vaginal bleeding, but normal vitals, and hemoglobin is like low and low.
But not so low, right? Not so low. 110 is fine.
No, it's not so low. Yeah.
Yeah.
Combined OCP, IV conjugate estrogen, levonorgestrone, and triotrine device, oral medroxyprogesterone. Okay, so.
Dr. Masuda said, okay. Which one would you go for, Dr. Masuda?
OCP, because she's smoker more than 35, it's not a good option.
Okay.
Conjugate estrogen, IV.
You go for that one.
The levonorgestrone triotrine device. This is IUD, hormonal IUD, oral medroxyprogesterone. Yeah, I think D.
You go for D. So now tell me, walk me through. Why didn't you go for A? Why didn't you go for B? Why didn't you go for C? Why are you going for D? So Dr.
IUD, in IUD, we don't give IUD in patients with bleeding, unknown bleeding.
Okay.
Oh yeah, she's bleeding, so I don't think, no A, no C. But
no A, no C. Okay. So what about IV conjugated estrogen?
Estrogen.
Yeah, conjugated estrogen. Will you do that? IV.
Yeah, IV estrogen. Still, I don't think so, because smoker, elder, like more than 35, this we don't recommend estrogen. But
okay,
oral
so now the indication for IV estrogen is in a hemodynamically unstable patient. Okay.
Yeah, it's not.
Yeah, but this patient is hemodynamically stable. Secondly, this patient, as you said, you were reasoning through it awesome, and you said you were going to go for D. Number one, you will not want to give combined oral contraceptives. Why? Because the patient is more than 35 years, and the patient is a smoker, right? Number two, IV conjugated estrogen, the patient is hemodynamically stable. Okay. Number C, levonorgestrone. Levonorgestrone can help to decrease bleeding, but you don't use it in the emergency situation. So we've been able to think and reason through all these. So the number one answer you want to go for, as you said, would be D. All right. So the answer is D, like what you said. And the reasoning is very simple. In a female with bleeding per vaginum, you want to monitor the ABCD first and rule out pregnancy. But in the question, pregnancy was ruled out, and ABC seems to be normal because we are told that the patient is hemodynamically what? Stable. All right. So now, if stable, you can use oral contraceptive agents, tranexamic acid, non-steroidal anti-inflammatory drugs, and medroxyprogesterone. However, tranexamic acid was not in our answers. NSAIDs was not in our answers. And we learned that this patient is a smoker and she's 35, she's 38 years. And we know that being more than 35 years and being a smoker is a contraindication to the use of oral contraceptive pills. So oral contraceptive pills is out, tranexamic acid is out, NSAIDs is out. The only option we have now is medroxyprogesterone. So now medroxyprogesterone is the option of choice. since there are contraindications to estrogen therapy, like smoking in patients over 35 years, which this patient has those contraindications. So Dr. Masuda, that was awesome. You did it wonderfully. Now, another teaching point is this. IV conjugated estrogen is used, but for severe cases. And obviously, this patient is not in any severe case. Okay? As well, levonorgestrel intrauterine system is indicated for contraception, but not for the acute management of dysfunctional uterine bleeding. So what you said was also right. So in other words, this introduces us to the concept of contraindications to hormonal therapy. And this one, you must know it from at the tip of your fingers, because contraception is bread and butter family medicine. And you can't prepare for any Canadian exam without reviewing your contraception, okay? So you've got to know the contraindications to all hormonal therapies, including stroke, thromboembolic disease, active liver disease, past or current breast cancer, and pregnancy. So the take-home point from this case and this teaching point is this: combined oral contraceptives are contraindicated in smokers aged 35 years and older, and medroxyprogesterone can be used as an alternative for the dysfunctional uterine bleeding. However, don't forget, if somebody has dysfunctional uterine bleeding, you can use combined oral contraceptives, you can use tranexamic acid, you can use NSAIDs, you can use medroxyprogesterone, but you must know when you want to use any of them. For example, if the person has bleeding disorder, you want to be careful about tranexamic acid. If the person has stomach ulcers and kidney disease, you want to be careful about NSAIDs. And in this patient who is older than 35, smokes, you want to be careful about oral contraceptives. But then progesterone then becomes a very good option. So you see the way we've reasoned through it. So once again, I want to state, the MCQs is not guesswork. The MCQs, each MCQ has an MCC objective that you must know, and based on that, choose your answers wisely. But then let's go to the objective for today: early pregnancy loss and spontaneous abortion. This is an MCCQ objective, and MCC objective, sorry, and it is objective 81. So with objective 81, what they want you to do is to learn how to construct an effective initial management plan, including the people who need emergent management in case of hemodynamic instability. So like if you have a patient who has ruptured ectopic pregnancy, you've got to know that that one you need to call the specialist. Those who also need to be referred for surgical evacuation or medical management, like incomplete abortions and missed abortions, if it is necessary. And this same objective wants you to know that if the patient loses a baby or loses a pregnancy, whether in the first trimester, second trimester, third trimester, you've got to be in a position to counsel the patient. You've got to talk about fertility implications. You've got to talk about contraception concerns. And you also have to know when to refer a patient for specialized care. So if the patient is having serious hemorrhage, like what we just discussed, or if the patient is having recurrent abortion from whatever cause, like antiphospholipid syndrome, or maybe if the patient has a uterine abnormality, you must be able to tell, who am I going to refer? Who am I going to resuscitate? Who am I going to even allow to go home? All right? So that's the essence of this MCC objective. So let's get into this. So you have a 25-year-old female who presents to the ED at a rural site. I need somebody to volunteer to answer this quickly for me. She's a gravida 3 para 1 with one alive at 8 weeks gestation with a confirmed urine pregnancy test. She has noted spotting for 3 days. And tonight she had bright red blood on her pad. The blood pressure is 100/70, the heart rate is 82, the respiratory rate is 20, and the oxygen saturation is 99% on room air. And the temperature is 36.5. List 5 differentials you will consider. Will somebody want to try? Dr. Lakimi, let's go. Dr. Lakimi, let's go.
Yeah, it can be threatened miscarriage.
Threatened miscarriage, yes. I'll write it down for you. Threatened miscarriage, what else?
Incomplete miscarriage.
Threatened, incomplete, awesome.
Unruptured ectopic.
What else? Threatened miscarriage, incomplete, what else?
Could be ectopic pregnancy.
Ectopic gestation. So I would rather even put ectopic gestation as number one. The reason is because you want to look at the thing which can easily kill the patient. Quick. So I'll put that one as number one. What else? So we've gotten 3. Ectopic gestation, threatened, incomplete. What else?
Trauma. Traumatic bleeding.
That,
Somebody is saying something.
Trauma.
Trauma. Okay. Yes, what else?
Abortion.
Hello? Yeah, Dr. Mahboobs have just texted me. She says, implantation bleed. Awesome. So, look, there are a lot of differentials for first trimester bleed. And ectopic, the reason why I'm saying ectopic pregnancy is, now there's another trick in answering your questions. If a question is asked, put the case which can easily kill the patient, the most dangerous cause up. Dr. Humera, you've raised your hand, please speak.
Yes, my question is about implantation bleeding. Implantation bleeding is possible at 8 weeks.
No.
Isn't it little early?
It is late, but then early gestational bleed, consider implantation bleed as one of them. But it is late. If I'm going to put implantation bleed, I'll put it down. Okay, but you still have patients who still bleed because of implantation bleed, like late around 6 weeks, 7 weeks. But don't put that as number one. So the trick is that, Dr. Redmi, please speak. Dr. Redmi, you raise your hand.
Can I have
Since the vitals are stable, is it possible to have ectopic pregnancy?
What?
Since the vitals are stable.
Yeah, you can still have ectopic pregnancy.
Okay.
And that is why you have some patients with ectopic pregnancy that you can manage with methotrexate. If their vitals are stable, and if it is not ruptured, and if it is less than, a particular size, and if it is not a heterotropic pregnancy, okay?
So the better answer should be unruptured ectopic pregnancy?
What?
Unruptured ectopic.
Yeah, you can just even write ectopic pregnancy. I think that should be fine. Okay. And if you write unruptured ectopic pregnancy, that's also fine. Usually, when you are being assessed, they don't just have one answer. They can say ectopic pregnancy, and they can write synonyms: unruptured, ruptured. Like they have synonyms. So if you use words which are similar to what they have, you still get your mark. Okay. All right? Yeah. So unruptured ectopic pregnancy can still cause bleed. And miscarriage, so we have incomplete, complete, threatened, septic, okay? All of those ones can cause bleed as well. And gestational trophoblastic disease, implantation bleed, even postcoital bleed. So the one who said trauma, so you realize that maybe, I don't know how they put it, but if you are being marked, they can say, okay, if the person says trauma, if the person says postcoital bleed, if the person says whatever, anything which falls in that category, that will also be given a mark. Condylomata acuminata. So if the person has, warts, genital warts, which bleed, chlamydia, gonorrhea, that is far-fetched. Okay, Dr. Tasman.
Yes, I have a question, please. So is placenta previa wrong answer if we say, I'm not sure.
Placenta previa is wrong because the patient is only 8 weeks. Yeah. Placenta previa is a cause of third trimester bleed. All right. So it's a good thing you talk about, but when you look at the gestation, placenta previa is third trimester bleed. Not around 8 weeks, placenta may not even be fully visible for you to say placenta previa. Okay.
Thank you.
So when you're talking about placenta previa, placental abruption, think about that in the context of third trimester bleed, not first trimester bleed.
Okay.
You got what I'm saying? Okay. So pelvic inflammatory disease, but those ones are low. What my point is this: when you are answering for CDM, list the most dangerous answers first. The ones which can kill the patient. List them first, because at times you may get your answers right, but maybe because you left ectopic pregnancy out, you may lose some marks. All right? Good. Dr. Mohammed.
Yeah, could you please tell us something about implantation bleeding? I could understand. What is that?
So when the fetus is implanting in the bed of the uterus, maybe let me unshare my screen and look for a Google image that will help us. Okay, implantation bleed. That will help us.
Thank you.
Yeah, I'm just looking for a picture for you. If I can find something like that.
Is it normal?
It is not normal. You should not bleed in pregnancy. However, the fact that the patient has implantation bleed does not mean that the pregnancy is going to be lost. Okay? So most of the time the patient has some implantation bleed, what you want to do is that you want to encourage bed rest and all that. So let me just get this funny picture. I didn't know this question was going to come. So what is happening is that the fetus gets, like the sperm fertilizes the ovum, and then they get implanted here, all right? When it is implanted, at times there's some hematoma which is formed, and occasionally there's some little bleed which comes out. But the baby is still viable and the baby is still fine. So in that case, we tell the mother, to stay away from maybe coitus, to get some pelvic rest and all that. And then they usually do very well.
So would it come under threatened abortion then?
There's threatened abortion and there's also implantation bleed. Those are two different things. But if you've not done an ultrasound and all that, you may just look at it and just say that is a threatened abortion. Yes, because most of the time, threatened abortion may not even present with pain. It may not present with pain, right?
Thank you.
You're welcome, Dr. Azam. Okay, so name 3 blood tests you will order immediately in this same patient. Name 3 blood tests. It didn't say name 3 investigations. Name 3 blood tests you will order immediately.
CBC.
Okay, so Dr. Azam, there we go. Let me say this. In the exam, don't say CBC. CBC is wrong. Rather, I know what you're trying to say. Say serum hemoglobin. Don't say CBC, okay? The same way, don't say liver function test. Say AST, ALT. Don't say renal function test. Say creatinine, urea, okay? Don't say CBC. Yeah. You can take your time and look at the MCCQE1 marking scheme. We'll talk about it. Dr. Redmi, please. So Dr. Mohammed, I know what you're talking about, but rather say serum hemoglobin rather than CBC. Dr. Redmi, you raise your hand.
Okay.
Hello, Dr. Redmi. Okay, maybe I'll just...
HCG?
Yes, I'm listening.
Beta HCG and coagulation profile.
Okay, so Dr. Redmi, you said beta HCG, but the question says blood test, okay? So you want to qualify that because we have urine beta HCG and serum beta HCG, okay? So qualify that with serum beta HCG, okay? And maybe you go for Dr. Mohammed's answer as well as hemoglobin. But in a pregnant woman who is having bleeding, what one test will you want to do as well, apart from your beta HCG and your hemoglobin?
Test, blood group.
Blood group. Blood group is very, very important. You realize that checking your blood group is a very critical thing in preparation for any patient who has bleeding. Please, any patient who has bleeding, especially in pregnant women, one of your first investigations should be blood group.
Blood group test, yeah.
The reason is because if you don't handle that carefully, the subsequent pregnancies can suffer, especially if the woman is like blood group O negative or A negative, and the partner is A positive or whatever, and then the baby is positive and you don't deal with the blood group issue, that can be a no-no. So sorry, Dr. Mohammed, this is wrong. I should not have written CBC, okay? I should have written hemoglobin, then type and screen, and then beta HCG. Even this beta HCG, I should rather write serum beta HCG. So even myself, I've made a mistake here. It should be serum hemoglobin, type and screen, and serum beta HCG, because the question says blood tests. Because you can have urine beta HCG as well. But since the question is saying blood tests, go for serum beta HCG. Go for.
I have a question, please.
Go for type. Okay, sure, Dr. Mohammed, ask your question.
Yeah, you know, CBC would include hemoglobin definitely, and will rule out any, you know, infection, cause of bleeding, you know, TLC, DLC, everything. So I think CBC should be done, not only hemoglobin.
I understand what you're talking about, but in the exam, they will say that they don't, even in the CCFP exam, they don't accept CBC. They accept serum hemoglobin, they accept WBC count. They will not accept CBC.
So we can't even write complete blood count?
No, don't write that. Okay. Write hemoglobin.
Okay, all right, thank you.
Write serum hemoglobin. Don't write complete blood count.
Okay, and we will write WBC count and differential.
Yes. So if it's a case of, you know, sepsis. So because this one, in this case, there's no need for you to write WBC count and differential. That is not a top blood work you want to do. Rather, you want to know the hemoglobin to know whether the patient is anemic. You want to know the blood group. You also want to know the serum beta HCG. Okay. So as I said, even my answers here, CBC, don't do that. Write hemoglobin, write type and screen, write serum beta HCG. Awesome.
Okay, thank you.
So now, the last one, the same patient. Further investigation indicates that the patient's blood group is A negative, same vitals. What is your next best step?
Rest. And also we can give progesterone.
What did you say? Dr. Iklas, you raised your hand. Please speak. Hello, Dr. Iklas. You raised your hand.
Yeah, we gave her Rogam.
Beautiful. That's it. Because that is the new thing which has been introduced here. Rogam. Dr. Redmi, you raised your hand. Speak. Dr. Redmi, you raised your hand.
NTD injection.
I didn't hear you.
NTD injection.
Anti-D, yeah. So that is the same thing. Rogam, Winro, Anti-D, they are all the same. If you write any of them, you still get your mark in the exam. Okay? Good. So you arrange for the patient to return to the ED in 48 hours to repeat beta HCG testing and a formal transvaginal ultrasound. The transvaginal ultrasound shows a crown ramp length of 8 millimeters and no fetal cardiac activity. The beta HCG was 2,300 2 days ago and is now 1,000. What is your diagnosis? What is your diagnosis? Dr. Redmi?
Missed abortion.
Missed abortion. Beautiful. Why? Number one, there's no fetal cardiac activity. Number two, the beta HCG level is dropping. So this is a case of missed abortion. So now this introduces you to the next question. Okay, how will you manage the patient? List 2. How will you manage the patient? Let's try to wrap things up. We've already gone almost 1 hour. How will you manage this patient? Dr. Esmat, now let's put on there. Dr. Esmat says inevitable abortion. Dr. Esmat, that can't be inevitable abortion. Inevitable abortion, you will realize that they will say that the cervix is opened. And at times in inevitable abortion, the fetal heart rate may still be there, but the cervix is open. So that means it is inevitable. It is going to come out. But missed abortion, most of the time, the cervix is closed, but then there's no fetal cardiac activity. Okay? So how will you manage this patient? Dr. Kwan Ling says he's going to give mifeprostone plus misoprostol. Dr. Yarlini says admit and gynecology consultation. Dr. Madhu says pre-vaginal misoprostol tap to initiate bleeding. Okay, so counselor refer to gynae. Dr. Simon Simpson says, Dr. A-class, please come to the table. How will you manage this?
According to the length of the pregnancy, either methotrexate or referred for DNC.
You said other what?
According to the gestational age. Either methotrexate or DNC.
Dr. Eklas, methotrexate is not indicated in missed abortion. I think you are confusing that with unruptured ectopic pregnancy. Methotrexate, we don't use that. Rather, we use mifeprostone, right? So we have 3 ways you can manage a case with missed abortion. In Canada, you can, if the patient is stable, the patient is sound, you can do expectant management, where at times the fetus itself will come out. Or you can do medical management with misoprostol, or you can do surgical management with suction and curettage. These are the 3 options you can do. And at times, you know, the burden of, oh my goodness, I carry the baby, it is dead and still in the uterus. So patients will rather opt that the doctors either give them misoprostol or to get the baby out. Okay? Yeah. So yeah, Dr. Simon said you can reassure and repeat beta ECG in 2 days and just check for it to go down. And that is what we call the expectant management. But at times the patient is too distressed that, look, I can't do this. Is dilatation and curettage an acceptable answer? Yes. So dilatation and curettage will become a synonym of suction curettage. That's it. So Dr. Javed, that is the answer. Okay. So teaching point, grief management in early pregnancy loss. Spontaneous abortion is medically common and its emotional impact is often underestimated. So remember that in the objective, it talked about the fact that you have to manage the grief of the patient as well. And so you've got to ensure the patient has appropriate emotional support with or without counseling. Okay, with or without counseling prior to discharge. So with the different types of abortions, as we try to wrap up, by the way, how have you enjoyed today's lesson? The way we've taken our time to break it down. What are you seeing with it? Very well. Awesome. So with the different types of abortions, the questions you have to ask yourself are these. Number 1, is the patient hemodynamically stable? If the patient is hemodynamically stable, that will determine, am I going to manage this patient on an outpatient basis or inpatient basis? As soon as you see a hemodynamically unstable patient, say respiratory rate is high, blood pressure is very low, pulse is high, you know you are not going to let the patient go home. Number 2, you want to ask yourself, is there pelvic pain? Is there abdominal pain? Number 3, is the cervix opened? Number 4, what are the ultrasound findings? Is there fetal heart present? And number 5, is there any signs or symptoms of infection like fever and the rest? All right? Because as soon as there's fever in the context of bleeding per vaginum in a woman who is in the first trimester, you are concerned about septic abortion. So this is a summary from Toronto Notes. You can check it out. In threatened abortion, I'm just summarizing everything. There is bleeding with or without cramping. As I said, they may or they may not be cramping. Usually the fetus is alive, not usually. In threatened abortion, the fetus is alive and the cervix is closed. So it answers all those questions we were talking about. How will you manage the patient? And remember, that's what I was talking about. Look up here. ROGAM is very, very important because as soon as the patient is O negative, whatever, you want to make sure you are arranged for ROGAM. In inevitable abortion, there's bleeding, there's cramping, there may be ruptured membranes. The fetus is low on ultrasound and the cervix is open. That one we call inevitable. No matter what you do, it's gonna come out. How are you going to manage the patient? You may want to do watch and wait so that the patient can come out on its own and becomes a complete abortion. Or you may want to give misoprostol 800 micrograms PV now and then maybe 800 micrograms later, okay? Just to get things going. In incomplete abortion, there will be bleeding, there will be cramping, and they will describe this as having tissue. On clinical ultrasound, you will see residual tissue in the uterus. Management, you either do watch and wait, or you give misoprostol, or you can do dilatation and curettage. In complete abortion means everything has come out. There's bleeding and complete passage of the sac and placental tissue. Usually the uterus is empty on ultrasound, the cervix is closed, and there's no further bleeding. If the patient is hemodynamically stable, no management is needed. Reassurance, counseling, grief counseling, and you can send the patient home. Missed abortion, as we learned, you can either do watch and wait, you can give your misoprostol, or you can do dilatation and curettage. 3 ways of managing it. And in recurrent abortion, you want to evaluate for any genetic condition, any mechanical issues, any environmental factors, okay? And in septic abortion, that means that the contents of the uterus are infected. So you will see tissue in the uterus, but the patient may be febrile. That's one, your management changes altogether. You want to give broad spectrum antibiotics. You want to start with broad spectrum antibiotics first, and then you may want to give misoprostol so that the contents can come out. Ladies and gentlemen, doctors, that is a quick review of that MCC objective.